Hi, good afternoon. It's an absolute pleasure to have the opportunity to talk with you about a topic I'm really passionate about. So my name's Eliot Siegel. I'm Vice Chair of Radiology at the University of Maryland, and I also have responsibility for the VA hospitals that are in the Chesapeake, Washington, D.C., West Virginia, Maryland area too. And I was asked to kind of give sort of a generic talk about topics related to communication of findings in radiology, which is something that I've really spent a lot of time thinking about and trying to address at the various institutions where I've worked. And so I know it varies from institution to institution. These are some data from Agamon looking at really large numbers of reports where they suggest that more than 10% of radiology reports contain follow-up recommendations for additional imaging. Actually, in my own experience, it's probably higher than that at the University of Maryland, and for chest CT, it's significantly higher than that. For us, it's as high as 40 to 50% of the studies that we do have some sort of follow-up recommendation that's made. And then in my experience at the VA, about 4% of the studies that we do have some important incidental finding that needs some kind of follow-up. And so, one of the challenges that we've always had is, in addition to our report, what is the additional responsibility of the radiologist in our relationship with the patient to be able to communicate that information? And so, we talk about actionable findings, and as we think of it, it really represents a finding that necessitates additional communication within a certain time frame or requires additional imaging, or a finding that needs a follow-up or additional studies or some other thing that needs to be done. And so I think many years ago the impression was that radiologists pretty much just need to create a report, and as long as it's done in a timely fashion, then that's kind of all we need. And then of course there's the responsibility that we have for emergency studies like an intracranial hemorrhage or a pneumothorax to be able to call and document that communication. But there are two other types of findings that kind of fall between the cracks. And one is kind of these incidental findings, and the other are recommendations that we make, whether or not we as radiologists believe that actually the recommendations will be followed up on. And so what has been documented with a really large number of studies, about 970,000 or so, has been about 50% of the cases in which a radiologist recommends a follow-up study. That follow-up study is not performed within the recommended time period. Now that's a huge amount of time, and at this point so much of that is falling between the cracks, where really we make the recommendation, but yet we don't really take responsibility to follow up to see if that's done, and really nobody necessarily does that. And the question is there a compromise in patient care associated with that? So there are lots of challenges administratively today, the shortage of radiologists and technologists. But from my own perspective, I realize that the hottest topic is probably shortage of radiologists and shortage of technologists, but I think from a clinical perspective, this loss of communication of findings, where we essentially find the pathology and then it's not communicated and doesn't result in action to the patients, is probably the biggest challenge that we have in radiology and have had for many years. And so doing tumor board at the hospital, I would find it relatively common that we would see a patient where the radiologist made the finding, and yet a year or so later, it wasn't followed up on. The patient comes back with metastatic disease or progression to the point where it's pretty much beyond where one is able to care for the patient. And so, this results in late diagnosis, increased liability, and lack of engagement with the patient. One of the interesting things that was done in this study with these 970,000 patients or so is they were able to document that about 14% of reports, about 1 in 7, are not even opened by the referring clinician. I would venture to say for ICU images and for orthopedic images, it's probably higher than 50%. And so we don't really have a mechanism in diagnostic imaging to track whether or not anyone's reading the reports that we're so assiduously creating. And about 47% of images are not opened. Now, this 14% was for neuroradiology. So you would think that for neuroradiology reports, it would be less than 14% that weren't even read. And for neuroradiology, 47% of imaging studies in this particular study were also not looked at. But what's more concerning to me is the number of reports that weren't looked at. So how did we address this issue at our institution over many years of experience finding out that patients were being lost to follow-up? And what we found, as I mentioned, was about 4% of the reports that we did had important findings that were not urgent, like a tension pneumothorax, for example. And so what we ended up doing was first asking the radiologist to follow up with referring clinicians. That was really difficult because tracking down the referring physician real time for things other than emergency studies was seen as burdensome to the radiologists. In our environment, especially in a teaching hospital, it was a challenge. So we ended up having our administrative staff, 4 of our administrators who were already, of course, doing other things. They would take and divide up those 4% of studies, each take about 1%. And the radiologists then would just go into the, as they were dictating in packs, would flag a study, and then that would be communicated to the administrative folks. The job of the administrative staff was to call either the person that had requested the study or their designee or the head of the department of surgery, medicine, ER, et cetera, and then also write a note in the chart saying that that communication had taken place. And then what we ended up doing after documenting it, which we found to be really important, is we found in 25% of cases, even after calling them and documenting in the chart the incidental finding and the recommendation, they still weren't being done. So what we found that we had to do was at the end of the month, we ended up calling and saying, hey, we recommended that you do this, but we haven't seen a request to be able to ask for this additional study or the action. So we ended up truly closing the loop in a way that we don't know any other program actually has. What that ended up doing is creating a dramatic decrease. It's almost unheard of now that we have patients where there's a significant finding where it fell through the cracks, and so the patient care improvement was really tremendous. The challenge with our workflow, as you have already anticipated, is the fact that not everybody has an administrative staff that would be able or willing to make those calls with the findings, track people down, and essentially then document in the chart and then follow up. And so it's a huge burden on the people that we have, but it's so valuable that we still end up doing it. The other problem is that throughout other hospitals, the VA and other places, practically nobody seems enthusiastic about having the resources, people resources, to do that. The other issue that we had, which is interesting, is there's variation. If we polled the radiologists in the group here as to what would be your criteria for an important incidental finding? Well, yeah, if you have a pathologic fracture of the humerus on a chest radiograph, that clearly is one. But is a positive myocardial perfusion study on a cardiac study, is that a significant incidental finding because they were looking for it? And so, we tried to create some information for our fellows and for new attendings as to what to call, but the variation is a major issue. And then the other issue that we have currently is we don't follow up on recommendations. So we only follow up on important incidental findings, but we make recommendations so commonly we don't have a mechanism to track. And in a lot of cases, the recommendations are kind of optional. Well, we recommend a 3-month follow-up or 6-month, but we're not saying it's got to be in 3 months or 6 months. So we don't really follow up recommendations per se. So where is it that we're hoping and planning to go in the future? Well, what we'd like to do would be to automate the process for our administrative staff by creating an automated system that allows one to be able to contact the appropriate physicians and then have backups and have an algorithm where there's a strategy to find the appropriate person. The biggest challenge of all, and I haven't seen any company be able to do this as successfully as I'd like to see, is being able to use natural language processing or some mechanism to determine in reading the report whether it should be one that gets flagged. So the radiologists do most of the flags now, but there's some level of inconsistency. And to have a system that would read the report and say, hey, you haven't flagged this, but this kind of falls within the scope of what would be flagged. So that is something where I'm really excited about natural language model or large language model processing or natural language processing being able to do. I'm still skeptical that even in 2023 we can do that, but I think the state of the art is getting better as time goes on with that. But the other thing that's really important are automating the other steps. The step of contacting the referring physician with the findings, the step of also being able to document in the chart that has happened. Documenting in the chart is really difficult because Epic and Cerner and most of the systems that we have don't allow one to write a progress note from a system. And so even though you can create a radiology report, you typically can't create a progress note. And so that's a challenge for automation, but we'd like to see automation write that same note that we do. And then we'd also like to see automation follow up to see whether or not the patient had the recommended study. In the Department of Veterans Affairs, most of the follow-ups are done within the VA system, so we have access to it. But most of the people outside the system, are kind of victims of the fact that care is really disjointed. You're not getting all your care from one hospital, one outpatient center, et cetera. So it makes it more difficult to determine whether the recommendation that had been made is actually followed up. And I think this is a real challenge. So, I'm really excited about the prospect of being able to have an automated system that essentially replicates the workflow that we have for the 3 administrators. And just to reiterate, what we want is to alert somebody as to what the finding is. We want to be able to document that we've had that conversation with a note in the chart, and we want to be able to follow up to see whether the recommendation had happened. And so we don't know any other places that are doing those things. And the other thing that we'd like to be able to do is have some mechanism where we can essentially track and follow recommendations that are made. And a lot of this gets to the philosophic question of what is the responsibility for the radiologist to the patient versus the responsibility of the radiologist to the referring clinician. And I know as an expert witness occasionally, the courts that I have essentially interacted with really believe that there is a relationship between the radiologist and the patient and holds us to some level if we make a recommendation or there's an incidental finding or there's a perception that we should have communicated it, that there is documentation not only of the fact that we made the finding, but even potentially, as we do, to find out whether or not the follow-up or the recommendation was actually done. And I think in 2023, with the AI systems and automation that we have, we really ought to move forward taking that. And I think if we do, we will really significantly increase the relevance of radiology as a practice and of we radiologists. So I'd just like to thank Agamon who have addressed this issue for inviting me to kind of give a generic talk. I don't really have experience at this point yet. I'm hoping to at some point soon with Agamon per se. But I just wanted to talk about the general issue, how we've addressed it manually, and how we're excited for solutions such as theirs to be able to address this issue. So thank you all very much for coming to attend around lunchtime. I really appreciate it, and hope you're passionate about this issue too. Thanks. I'd love to take questions, but I don't think we're allowed to take questions up here, so thanks.